Good afternoon, everyone. We'll wait for 2 more minutes for everyone to join, and then we can start the session. Okay, good afternoon. Welcome everyone to the 2024 HackMedTech launch. My name is Mary Susan Thompson. I'm a project manager at the Science Research Innovation Office at Toronto Metropolitan University and the program manager for the MedTech Talent Accelerator, an NSER created funded program. Along with me in this Zoom meeting is Mr. Adnan Said, Manager, Research Programs, Partnerships and Strategic Initiatives, Faculty of Science, Toronto Metropolitan University, Director for Talent Accelerators, and Ms. Rumen Ismdar, Student Affairs Administrator, Department of Biomedical Engineering, Faculty of Medicine and Health Sciences, McGill University, and Project Manager for the MedTech Talent Accelerator Program from McGill. I'm pleased to welcome Dr. Ali Tavale to introduce the HackMedTech Challenge during the launch event of HackMedTech 2024. As a Canada Research Chair in Systems and Devices for Cardiovascular Interventions at Toronto Metropolitan University, Dr. Tavale's expertise and contributions to the medtech industry will undoubtedly inspire and guide our participants in this exciting competition. He is an assistant professor at the Department of Electrical, Computer, and Biomedical Engineering at the Faculty of Engineering and Architectural Science at Toronto Metropolitan University. He is also a visiting scientist at Sunnybrook Research Institute, an assistant professor at the Department of Electrical and Computer Engineering at the University of Toronto, and an affiliate scientist at the IBES Research Center. Dr. Tavale has been engaged with multiple medical device startups and is currently the president and co-founder of Magellan Biomedical Incorporated. We are thrilled to be hosting HackMedTech 2024, which is made possible through the NSER Create program and its valuable partners, Toronto Metropolitan University, McGill University, Dalhousie University, the University of Calgary, and the University of Toronto. These institutions, alongside industry leaders, are dedicated to nurturing the next generation of talent by providing students the opportunity to address real-world challenges in the medical technology sector. A special acknowledgement goes to Fasken, our generous sponsor for this year's prize awards. Fasken's extensive expertise in the medtech field, combined with their support for innovation and entrepreneurship, is vital in enabling our participants to bring their innovative solutions to life. Fasken is a leading international law firm with extensive expertise in the medical technology sector, with offices across Canada, the UK, South Africa, and beyond. Fasken provides crucial legal service, including regulatory compliance, intellectual property protection, and corporate transactions. Their deep understanding of medtech challenges helps clients navigate complex regulations, safeguard innovations, and achieve strategic goals while managing legal risk. HackMedTech 2024 promises to be an exciting platform for students from diverse disciplinary backgrounds to collaborate, network, and develop groundbreaking solutions for the early detection of cardiovascular diseases. We look forward to seeing the remarkable ideas and innovations emerging from this year's hackathon. Please keep your mics mute and videos off until the launch presentation ends. Feel free to post your questions in the chat or ask directly after the presentation. Best of luck to all the participants, and let's make this year's HackMedTech an unforgettable experience. Over to you, Dr. Tyrell.
Thank you, Suzanne, for that kind introduction. Hello, everyone. Pleasure to be here and seeing you from across Canada. And welcome to this challenge and this event. So I'm happy to share my presentation and the way I thought, there was many ways to, I guess, structure this presentation. I figured it was best to talk about the main cardiovascular diseases. So I'll talk about, the main cardiovascular diseases that are out there, specifically atherosclerosis, heart disease, aortic diseases, and the corresponding risk factors that affect them. And I thought it's best to stay away from actual specifics on solutions because I don't want to be guiding anybody through my own narrow lens of experience on solution generation. But the problems or the clinical problems are standing. But I will share some potential strategies that may be beneficial for addressing some of these diseases and the challenges in these diseases. And then the second part of the talk, and hopefully in between these two parts, we'll have a little 5-minute bio break or a recess. I'll talk about the need identification and selection process. These are primarily from another talk that I had before, but it's very directly relevant. So I thought I share that with you as well. So just making sure that all the slides are being visible, everything is good. Otherwise, Mary, please let me know. Otherwise, in terms of the cardiovascular diseases, I will talk about atherosclerosis and how specifically it's unfortunately a chronic inflammatory disease that leads to various other problems, including coronary artery disease, cerebrovascular diseases, peripheral artery diseases, and then we'll talk some of the main heart diseases such as arrhythmias, congenital heart defects or diseases, valvular disease or heart valve disease, cardiomyopathies, and aortic diseases. And then we'll talk about the risk factors after that. But just starting from this, the vessel, as we prep to talk the discussion around atherosclerosis. So the one of the key features of our arteries is they have multiple layers, and this most inner layer in which blood is carried is referred to as the endothelium layer. Okay, so this is a very important layer, and many diseases affecting this layer could lead to a bunch of other problems, and specifically atherosclerosis, as we'll discuss next. But this layer plays a key role in controlling the passage of fluids from the blood to our organs and other tissues. And it's very important that it stays healthy and it's in charge of, contraction and dilation, and produces very important chemicals such as nitric oxide, and it prevents coagulation of the blood and so forth. So it's very important for it to be healthy. But unfortunately, in many of us, that isn't the case, and many factors such as mechanical stress or glucose or other complications lead to its damage, and that manifests itself as atherosclerosis. So what is atherosclerosis? Let's watch this video, and the link is shared here if you want to watch it later to learn more about atherosclerosis.
Atherosclerosis is a progressive process in
Please let me know if you don't hear the sound, by the way.
in which inflammation plays an important role. In the presence of inflammatory stimuli such as elevated LDL-C, atherosclerosis develops as vascular endothelial cells express adhesion molecules that capture monocytes on the arterial wall.
So just to highlight again, like this could be due to mechanical stress, could be due to presence of glucose or other types of genetical factors. But for some reasons, this endothelial layer has a tendency to attract these monocytes and it becomes damaged. And the bad cholesterol or LDL finds its way to the inner layers.
Same time, changes in the permeability of the arterial wall allow the entry and retention of LDL-C particles and monocytes. As monocytes enter the arterial wall, they engulf LDL-C particles and become lipid-filled macrophages known as foam cells, which aggregate as fatty streaks, the hallmark of early atherosclerosis and plaque development. This process promotes the release of multiple pro-inflammatory cytokines, which act as key mediators of inflammation and drive plaque progression within the arterial wall. Plaque progression involves smooth muscle cell migration within the arterial wall and increased production of extracellular matrix molecules. As atherosclerosis progresses, macrophages and smooth muscle cells die within the plaque, releasing their accumulated lipids to form a necrotic lipid core within the plaque. They also secrete thrombogenic factors, which degrade the fibrous cap, making it vulnerable to rupture and contributing to thrombosis, which can lead to cardiovascular events.
So, one of the main side effects of this atherosclerosis manifests itself in the heart, in the coronary arteries of the heart, and correspondingly leads to coronary syndromes. So, let's see what that means and how it can cause complications in our heart.
Acute coronary syndrome, ACS, is a group of conditions that occur when blood supply to an area of the heart muscle, the myocardium, is suddenly reduced or blocked. Reduced blood supply is termed ischemia. A prolonged ischemia can lead to death of the heart tissue, known as heart attack or myocardial infarction. A typical symptom of ACS is central chest pain or discomfort that may spread to the back, jaw, left shoulder, or arm. The pain may also be felt in the abdomen and can be mistaken for shortness of breath, heavy sweating, nausea, palpitations, and fainting. Women and older people often have atypical symptoms. Chest pain is not reported in about 30% of cases. About 20% of patients have mild or no symptoms. Risk factors include aging, family history of heart diseases, smoking, diabetes, hypertension, high cholesterol, obesity, style, unhealthy diets, and psychosocial stress.
One of the things I would emphasize is, as we go through these videos and talk about these various diseases, that you pay attention to these risk factors. There's a lot of evidence, and especially in cardiovascular disease, a lot of data that correlates these various risk factors to the outcome or the path of the disease. And maybe we're not able to directly make measurements on the disease, but we're able to make measurements on these risk factors and have estimation. Okay, so it's very important for us to pay attention to these risk factors. Sometimes they're a lot easier to measure and observe and quantify. Okay. And just to note on what you're seeing here on the right side of the screen is the PQRST cardiac electropotential or the ECG signal. And when you hear, for example, ST elevation, you mean this part of this wavefront is elevated or flat and whatnot. So just if you hear the term ST, or if you hear referral to any of the P wave, for example, for the atrial function, or the ventricular function, the R wave and whatnot, that's what we're referring to.
The most common cause of ACS is the formation of a blood clot in an artery already narrowed by an atherosclerotic plaque. Plaques are deposits of lipids, fibrous tissue, and calcium that accumulate slowly over time. A plaque may become inflamed and rupture, exposing substances that promote coagulation, producing a blood clot on top of the plaque. Less common causes include coronary artery embolism, coronary spasms, and coronary artery dissection. Depending on the location and the extent of obstruction, one of the following conditions may result: unstable angina, non-ST segment elevation myocardial infarction, non-STEMI, or ST segment elevation myocardial infarction, STEMI. These conditions are differentiated based on ECG findings and cardiac marker levels. Markers are substances released into the bloodstream upon death of cardiac myocytes. Cardiac troponins are the markers of choice as they become elevated early in the disease process. The amount of troponin released is proportional to the infarct size. Most patients with infarction show elevated troponin levels within 6 hours. Troponin assay is usually done on presentation and then repeated a few hours later. Unstable angina is basically ischemia without infarction. It impairs cardiac function but has not caused cell death. ECG changes are absent or transient. Cardiac troponin levels remain normal or only slightly elevated. It should be noted, however, that this condition is clinically unstable and often precedes a myocardial infarction. Non-STEMI is infarction that is limited to the inner layer of the ventricular wall. Cardiac marker levels are elevated as a result of myocardial cell death. ECG changes may include ST segment depression or T-wave inversion, but not ST segment elevation. STEMI is infarction that extends the entire thickness of the myocardium. STEMI results from a complete and persistent occlusion of blood flow. ECG findings show a characteristic ST segment elevation. There is usually a reciprocal ST depression in the electrically opposite leads. The location of infarction can be identified based on the leads with ST elevation.
So it's very important that you become familiar with the 12-lead ECG system. Some of these assume you have knowledge of that. If not, please just after this presentation, I guess quickly become familiar with just the standard 12-lead ECG and what these mean. But generally, we're just, if you have a cardiac vector that's moving around in 3D space as a function of the heart's electrical activity, that vector has projections and along different dimensions, and that's what we're able to pick up with the 12-lead ECG. And when we're talking about these various segments, that's all we're talking about.
Occlusion of blood in the electric markers are elevated. All patients with suspected ACS are treated promptly with antiplatelets, usually aspirin, angina medications, usually nitroglycerin, and supplemental oxygen if required. Once diagnosis is confirmed, anticoagulants, beta blockers, ACE inhibitors, and statin are usually initiated within 24 hours unless otherwise contraindicated. For STEMI patients, emergency percutaneous coronary intervention, PCI, is the preferred procedure to restore blood flow. If PCI is not available, a fibrinolytic therapy is usually initiated at the earliest possible time. For patients with unstable angina or non-STEMI, an angiography to identify sites of blockage may be done within 24 to 48 hours if the patient is clinically stable and the case is uncomplicated. For complicated cases, angiography must be done immediately. Fibrinolytic therapies are not indicated for non-STEMI patients.
So why is this important? Well, coronary artery disease is the leading cause of death worldwide. And it's still the case, and it has been for quite some time. So in the US, 18 million adults over 20 years of age have coronary artery disease, and affects about 6.7% of the population and leads to 1 in 7 deaths in the US. So it's quite a significant problem. and it's the most common type of heart disease. And it's, as you can see, it obviously leads to myocardial infarction, with 1.5 million heart attacks occurring annually in the US alone. So 50% of men and 64% of women who die suddenly from CAD had no previous symptoms, which is quite alarming. So we have to have a better method of being able to detect that this is present before in the absence of any potential symptoms. So what are the risk factors? Their major risk factors include high blood pressure, we'll talk about that, high cholesterol, obviously the role of LDL-C is key, diabetes and glucose, smoking, obesity, and the sedentary lifestyle. There's also stress and other factors, and alcohol and cocaine and drug that are also risk factors. Obviously, family history is key. Genetic factors are clear, and so it's early detection is typically extremely valuable, and it may be done through stress testing, calcium scoring, and geography, as was mentioned. And lifestyle changes and medication are very important. And in all of these diseases, this is a recurring theme. This is, I think, very important for you to pay attention to, is a lot of times patients rather die than change their habits or change their lifestyle. This is reality, sad reality for most of us. It's very difficult to change our habits. So how do we do that? Like that's, I think, still an outstanding question. How do we help patients change their habits or lifestyles? And that's obviously the case with coronary artery disease. And we talked about, I think, the procedures and treatment options already. So what about what about in the brain? What complications could we potentially have in the brain as a result of this, atherosclerosis and other complications? Let's look at this video on cerebrovascular disease.
A stroke occurs when the blood supply to a certain part of the brain is reduced or interrupted. Without oxygen and nutrients from the blood, brain cells cannot function properly and eventually die. There are two major types of strokes: ischemic artery and hemorrhagic stroke caused by a ruptured artery. Ischemic stroke happens when a blood clot obstructs an artery. In some patients, the clot forms locally inside the blood vessels that supply the brain. This occurs when fatty deposits in an artery or cholesterol plaques rupture and trigger blood clotting. In other cases, a clot may travel to the brain from elsewhere in the body. Most commonly, this happens in patients with atrial fibrillation, a heart condition in which the heart does not pump properly. Blood stagnates in its chambers, and this facilitates blood clotting. The clots may then pass into the bloodstream, get stuck in smaller arteries of the brain, and block them. Hemorrhagic stroke, on the other hand, occurs when an artery leaks or ruptures. This can result from high blood pressure, overuse of blood thinners, anticoagulant drugs, or abnormal formations of blood vessels, such as aneurysms and AVMs. As a hemorrhage takes place, brain tissues located beyond the site of bleeding are deprived of blood supply. Bleeding also induces contraction of blood vessels, narrowing them and thus further limiting blood flow. Stroke symptoms may include one or more of the following: paralysis of muscles of the face, arms, or legs, inability to smile, raise an arm, or difficulty walking, slurred speech or inability to understand simple speech, sudden and severe headache, vomiting, dizziness, or reduced consciousness. Cerebral stroke is a medical emergency and requires immediate attention. It is essential to determine if a stroke is ischemic or hemorrhagic before attempting treatment. This is because certain drugs used for treatment of ischemic stroke, such as blood thinners, may critically aggravate bleeding in hemorrhagic strokes. For ischemic strokes, emergency treatment aims to restore blood flow by removing blood clots. Medications such as aspirin and tissue plasminogen activator, TPA, are usually the first options. TPA may be given intravenously, or in the case the symptoms have advanced, delivered directly to the brain via a catheter inserted through an artery at the groin. Blood clots may also be removed mechanically by a special device delivered through a catheter. Emergency treatment for hemorrhagic strokes, on the other hand, aims to stop bleeding, reduce blood pressure, and prevent vasospasm and seizures. These goals are usually achieved by a variety of drugs. If the bleeding is significant, surgery may be required to drain the blood and reduce intracranial pressure. Preventative treatments for strokes include removal of cholesterol plaques in carotid arteries that supply the brain, widening of narrowed carotid arteries with a balloon and sometimes a stent. This is usually done with a catheter inserted at the groin. Various procedures to prevent rupturing of brain aneurysms, such as clipping and embolization of vascular malformations, bypassing the problematic artery. Thank you.
So again, with regards to stroke, it's when you combine disability and death, it's the leading, it's leading everything else. 12.2 million people worldwide each year. And in the US, around 800,000 people experience a stroke annually, with 610,000 being first-time strokes. Global strokes is responsible for 6 million deaths annually, making it the second leading cause after coronary artery disease. Approximately 50% of stroke survivors are left with some long-term disability. So even if you survive, you still have this disability that you have to deal with. So it's very important to be able to predict it in advance. It drastically reduces, if you can predict it in advance, drastically reduce the burden on the healthcare system and the burden on the patient, and obviously mitigate the risk of death. But as was mentioned, several factors are very important. Atrial fibrillation increases the risk of stroke 5-fold. This is significant. So that's why the Apple Watches and the like that help you estimate atrial fibrillation are extremely valuable. High blood pressure, smoking, high cholesterol, obesity, diabetes, and obviously atrial fibrillation are all major risk factors. So if you can detect it early on, you can help reduce the risk of long-term disability. And if you administer TPA within the first few hours, so if you have a may of determining it early on, the outcomes can be drastically improved. Thrombectomy, as was shown, can also be used to actually retrieve the clot and whatnot, ideally within the first few hours again, which is a lot of challenges to actually, first of all, even to just tell the patient has had stroke immediately itself is still an outstanding need. So this also manifests itself, maybe you take him for granted, but atherosclerosis also is present in our legs. And unfortunately, about every year, we have about 500,000 patients that end up being amputated because of peripheral artery disease. It's a significant number when you think about it, especially that once you're amputated, your risk of mortality goes up to 80% immediately within the next 3 or 4 years. And also, there's a bunch of other risk factors associated with peripheral artery, but let's see what that is.
Peripheral artery disease, PAD, is a common circulatory condition in which peripheral arteries are narrowed, reducing blood flow. While PAD can occur in any organ or body part, the lower limbs are the most commonly affected. The major cause of PAD is the building up of plaques in arteries, known as atherosclerosis. Plaques are deposits of lipids, fibrous tissue, and calcium that accumulate slowly over time. Less commonly, an artery may suddenly be blocked by a blood clot or embolus. Rarer causes include blood vessel inflammation, injury, or unusual anatomy of ligaments or muscles. The impact of reduced blood flow or remarkable when there is a higher demand for blood supply, such as during physical activities. This is why people who are not very active may not experience any symptoms initially. It also explains the most telltale sign of PAD, known as intermittent claudication, a painful or tired feeling in the legs that occurs while walking, but is rapidly relieved by rest. The affected leg and foot may lose color and feel cold, especially when the foot is elevated. There may also be a lack of growth of toenails and hair. The location of pain depends on the site of obstruction. The more proximal the site of blockage, the more widespread the pain. The calf is the most common site of pain. As the disease progresses, patients may experience pain even during rest. This advanced stage is known as critical limb ischemia, a chronic, slow-developing condition. Patients may develop ulcers that heal slowly or not at all, and death of tissue or gangrene may occur. The risk for loss of limb is significantly increased at this stage. Acute limb ischemia happens when there is a sudden block of blood flow, typically due to an embolism or thrombosis. Acute limb ischemia is an emergency threatening loss of limb. Any factors that increase risks for atherosclerosis also increase risks for PAD. Because atherosclerosis can affect any artery in the body, PAD patients are also likely to have coronary artery disease or carotid artery disease. Diagnosis is based on symptoms, medical history, physical exam, and a number of tests. The purpose of the physical exam is to look for signs such as weak pulses, whooshing sounds of obstructed blood flow, and evidence of poor wound healing. Blood tests are done to evaluate cholesterol, triglyceride, and blood sugar levels. Ankle brachial index test, or ABI test, is commonly performed to compare blood pressures in the ankle and the arm. An ABI lower than 0.9 indicates PAD. Imaging procedures may be arteries. Treatments aim to relieve symptoms, re-establish blood flow to reduce risk of losing a limb, and stop progression of atherosclerosis to lower risk of heart attack and strokes. Treatment options include lifestyle changes, exercise programs, medications, and/or procedures to open or bypass blockages in the arteries.
So in the US alone, there's up to 12 million people with PAD, and it's rapidly increasing. As I said, there's 230 million people globally suffering from this disease. And it increases the risk of heart attack and stroke 2 to 6 times, which is, again, a significant contributor. So early detection of this disease is also has major implications for the patient and the healthcare system. So we already talked about, I think, the symptoms, but 50 to 75% of individuals with PAD are asymptomatic. Okay, so this is, I think, an outstanding need where you have such a severe issue with so many potential implications, but unfortunately, majority of those patients are asymptomatic and you don't even know about it. So early detection is very challenging, but extremely crucial and valuable. I think we talked about the ABI index, ankle brachial index, and the treatment options. So I can, for the sake of time, skip to that. So the other big problem is arrhythmias, and as we already talked about, briefly touched on atrial fibrillation, but there are a number of other arrhythmias. All of them, again, significantly important and may contribute to emboli or clot formation and stroke or other complications.
Cardiac arrhythmias can be classified by site of origin. Sinus rhythms originate from the sinoatrial node, or SA node. Atrial rhythms originate from the atria. Ventricular rhythms originate from the ventricles. Sinus rhythm is the normal rhythm of the heart set by its natural pacemaker in the SA node. In a healthy heart, the SA node fires 60 to 100 times per minute, resulting in the normal heart rate of 60 to 100 beats per minute. Variations of sinus rhythm include sinus bradycardia, when the SA node fires less than 60 times per minute, resulting in a slower heart rate of less than 60 beats per minute, and sinus tachycardia, when the SA node fires more than 100 times per minute, generating a faster heart rate of greater than 100 beats per minute. Sinus bradycardia and sinus tachycardia may be normal or clinical depending on the underlying cause. For example, Sinus bradycardia is considered normal during sleep, and sinus tachycardia may be normal during physical exercises. Cardiac arrhythmias that originate from other parts of the atria are always clinical. The most common include atrial flutter, atrial fibrillation, and AV nodal reentrant tachycardia. These are forms of supraventricular tachycardia, or SVT. Atrial flutter, or A-flutter, is caused by an electrical impulse that travels around in a localized self-perpetuating loop, most commonly located in the right atrium. This is called a reentrant pathway. For each cycle around the loop, there is one contraction of the atria. The atrial rate is regular and rapid, between 250 and 400 beats per minute. Ventricular rate, or heart rate, however, is slower, thanks to the refractory properties of the AV node. The AV node blocks part of atrial impulses from reaching the ventricles. In this example, only 1 out of every 3 atrial impulses makes its way to the ventricles. The ventricular rate is therefore 3 times slower than the atrial rate. This is an example of a 3-to-1 heart block. Ventricular rate in A-flutter is usually regular, but it can also be irregular. On an ECG, atrial flutter is characterized by absence of normal P wave. Instead, flutter waves, or F waves, are present in sawtooth patterns. Atrial fibrillation is caused by multiple electrical impulses that are initiated randomly from many ectopic sites in and around the atria, commonly near the roots of pulmonary veins. These unsynchronized chaotic electrical signals cause the atria to quiver or fibrillate rather than contract. The atrial rate during atrial fibrillation can be extremely high, but most of the electrical impulses do not pass through the AV node to the ventricles, again thanks to the refractory properties of the cells of the AV node. Those that do come through are irregular. Ventricular rate, or heart rate, is therefore irregular and can range from slow, less than 60, to rapid, more than 100 beats per minute. On an ECG, atrial fibrillation is characterized by absence of P waves and irregular narrow QRS complexes. The baseline may appear undulating or totally flat depending on the number of ectopic sites in the atria. In general, larger number of ectopic sites results in flatter baseline. AV nodal reentrant tachycardia, or AVNRT, is caused by a small reentrant pathway that involves directly the AV node. Every time the impulse passes through the AV node, it is transmitted down to the ventricles. The atrial rate and ventricular rate are therefore identical. Heart rate is regular and fast, ranging from 150 to 250 beats per minute. Ventricular rhythms are the most dangerous. In fact, they are called lethal rhythms. Ventricular tachycardia, or VTach, is most commonly caused by a single strong firing site or circuit in one of the ventricles. It usually occurs in people with structural heart problems such as scarring from a previous heart attack or abnormalities in heart muscles. Impulses starting in the ventricles produce ventricular premature beats that are regular and fast, ranging from 100 to 250 beats per minute. On an ECG, VTach is characterized by wide and bizarre-looking QRS complexes. P wave is absent. VTach may occur in short episodes of less than 30 seconds and cause no or few symptoms. Sustained VTach lasting for more than 30 seconds requires immediate treatment to prevent cardiac arrest. Ventricular tachycardia may also progress into ventricular fibrillation. Ventricular fibrillation, or VFib, is caused by multiple weak ectopic sites in the ventricles. These unsynchronized, chaotic electrical signals cause the ventricles to quiver or fibrillate rather than contract. The heart pumps little or no blood. VFib can quickly lead to cardiac arrest. VFib ECG is characterized by irregular random waveforms of varying amplitude with no identifiable P wave, QRS complex, or T wave. Amplitude decreases with time from initial course VFib to fine VFib and ultimately to flatline.
So atrial fibrillation is unfortunately very common. It's estimated that 33 to 59 million individuals worldwide have AFib, and it's expected to double by 2050 due to aging populations. In the US, about 12 million people are projected to be living with AFib. Unfortunately, I guess this is the problem, that AFib, unfortunately, increases the risk of stroke 5-fold. And so it's very important to be able to detect if a patient has AFib early on. And one of the common reasons of stroke in young adults is because they had AFib and they didn't know. AFib is associated with 2x risk of all-cause mortality and contributes to 20 to 30% of all ischemic strokes. Major risk factors include obviously age, hypertension, diabetes, both of them very common recurring risk factors, as we'll see, heart failure and other underlying heart diseases. Obesity, physical inactivity, and excessive alcohol consumption can also contribute. So one more disease of the heart is the disease of the heart valves. And this is also a significant problem. So let's see what we mean by these valvular heart disease.
Valve disease is a common form of heart disease. If you or someone you know has heart valve disease, it's important to know what it is and how it occurs. Your heart has 4 valves that keep blood flowing in the right direction: tricuspid, mitral, pulmonary, and aortic. Each valve is like a one-way door. During each heartbeat, the valves open to let blood flow from their chambers and close to stop the blood flowing backwards. Heart valve disease means that one open or close properly. This can cause the blood flow through your heart to and from your body to be disrupted. There are a few types of heart valve disease, but they usually fall into one of 2 categories. Stenosis is when your heart valve open properly. This can reduce blood flow, which causes strain on your heart. Regurgitation or insufficiency is when your valve flaps are leaky and don't close properly. This lets blood leak back through your valve and can make your heart work harder to circulate blood around your body. Most valve problems can be managed with a procedure or surgery to fix or replace the affected.
So again, the prevalence of valvular heart disease is quite significant. In the US alone, it's estimated 13 million people have this disease, and affects about 12% of individuals over 75. Aortic stenosis is the most common form of valve disease and affects about 2% of people over 65, and has a 50% mortality rate within 2 years of symptom onset if left untreated. Again, risk factors include arrhythmia and stroke, and other complications could eventually, diabetes as well, I'm guessing, could contribute to risk factors as to valvular heart disease. So it's very important to also be able to detect this early on to prevent complications, to prevent clot formation and heart failure as expected. Then the other significant disease of the heart is cardiomyopathy. And there's various kinds of cardiomyopathy, but let's first learn about what it is and its corresponding, then we'll talk about its statistics.
Cardiomyopathy is a group of diseases that weaken the heart muscle, the myocardium, making it harder for the heart to pump blood. Cardiomyopathy reduces blood output and may lead to heart failure. The condition may be inherited from a parent or develop as a consequence of another disease or factor. Some patients do not experience any symptoms. When present, symptoms may include shortness of breath, beats, chest pain, swelling of lower limbs, dizziness, and fainting. Progression of the disease varies greatly from person to person. In some people, symptoms may appear suddenly and worsen quickly, while others see a gradual development over a long period of time. There are 3 major types of cardiomyopathy: Hypertrophic cardiomyopathy, or HCM, is the thickening of the heart muscle. Most commonly, this occurs in the interventricular septum facing the left ventricle. The thickened septum obstructs blood flow to the aorta, a condition called outflow tract obstruction or obstructive hypertrophic cardiomyopathy. Thickening elsewhere in the heart muscle causes non-obstructive HCM. In both cases, cardiac output is reduced. While HCM can develop as a result of high blood pressure or aging, it is most commonly inherited as an autosomal dominant trait. Children of an affected parent have a 50% chance of inheriting the disease. Multiple mutations have been identified in genes encoding for proteins of the heart muscle. Genetic screening is recommended as the disease may progress rapidly from asymptomatic to heart failure and cardiac arrest. In fact, HCM is the major cause of sudden cardiac death among young athletes. People who test positive for HCM are advised to avoid high-intensity activities. Dilated cardiomyopathy, DCM, is the thinning of the myocardium and enlargement of a heart chamber, most commonly the left ventricle. DCM is usually acquired, and the cause is unknown in most cases. Risk factors include high blood pressure, damage to the myocardium caused by previous heart attacks, alcohol or cocaine use, toxins or infections, and obesity or diabetes. While DCM may develop in anyone at any age, it is more common in men of middle age. Some DCM cases are inherited. Restrictive cardiomyopathy, RCM, is when the heart muscle becomes rigid, lacking the elasticity required to properly fill and pump blood. RCM usually results from building up of scar tissues or abnormal proteins, caused by a variety of conditions. RCM is more likely in older people. Less common types of cardiomyopathy include arrhythmogenic right ventricular dysplasia, a condition in which the right ventricle tissue is scarred, causing arrhythmias, and stress cardiomyopathy, or broken heart syndrome, a sudden temporary weakening of the heart muscle triggered by excessive emotional or physical stress. Treatment varies depending on the type of cardiomyopathy, the underlying cause, and severity of symptoms, and can range from lifestyle changes to medications and surgeries.
So perhaps less common, but it's still a big problem. Estimated 1 in 500 people worldwide has some sort of cardiomyopathy, including the various types that was mentioned. Hypertrophic cardiomyopathy is the most common inherited heart condition, and it's important point that it was mentioned. This is inherited. So by looking at the genes, you can identify factors or genes that could increase your risk of HCM. And it's very important that that's again unaddressed. Many people are unaware. So in severe cases, it can lead to heart failure or sudden cardiac death. Dilated cardiomyopathy has a 50% 5-year survival rate. So 50% of these patients, unfortunately, will die if left untreated. So as was mentioned, the risk factors, family history, and genetic factors are very important. Chronic high blood pressure can lead to dilated heart, for example, as was mentioned. Previous heart attacks is also important. And again, as was mentioned, it's very important to be able to detect this early to either do a surgery or, if needed, for example, address it with an intervention to predict the potential downstream risks. And there's various treatment options in terms of obviously medication as well as defibrillators. And worst case scenario, these patients would be candidates for heart transplants. And then there's also the congenital heart defects, unfortunately, in children.
Let's go over the different types of congenital heart defects. First up is tetralogy of Fallot. With this, you're going to have 4 abnormalities. Remember the word RAPS: right ventricular enlargement, aorta displacement, pulmonary stenosis, and septal defect, particularly a ventricular one. With this, patients are going to have TET spells, which is where they become cyanotic. To help relieve those spells, remember the knee to chest position. Next, with this, there is a hole in between the wall of the right and left ventricle. Remember the word hole. The patient's going to have heart failure and pulmonary hypertension, often has lung infections, low growth rate and weight, and extra heart sounds can be heard. Then there's atrial septal defect, which is similar to a ventricular septal defect, but there's a hole in between the right and left atrium. There's the same risk as VSD, however, you want to watch out for stroke, and a mid-systolic murmur at the second intercostal space at the upper left sternal border. Next up is transposition of the great arteries. Here we have two big arteries that have been swapped, the aorta and the pulmonary artery. So remember the word swap. The patient's going to have severe cyanosis at birth, that's persistent. Watch the heart rate, rhythm, oxygen saturation, and respiratory rate. Alprostadil is given to keep open the ductus arteriosus until surgery can be performed. And then procedures to fix include a balloon, atrial septostomy, or an arterial switch. Aortic coarctation is narrowing within the aorta. So before the narrowing, there's going to be high pressure, which can lead to heart failure. After the narrowing, the pressure will be low. Surgery can be performed to remove the narrow sections of the aorta and then reconnect the ends. This is usually done by 2 years old. However, later on, the patient may need a balloon angioplasty to reopen the artery if narrowing occurs again. And then lastly is patent ductus arteriosus. This is where the ductus arteriosus, which is normally present in the fetal heart, does not close after birth, and this increases pulmonary blood flow. Due to this, you're going to hear a continuous machinery-like murmur, and treatment includes endomethacin to close in some patients, but if that can't work, surgery can be performed. Let's go over.
So 1 in 100 births is affected by congenital heart defects, and making it the most common type of birth defect. So in the US, a lot of these are caught early on and interventions are done. So 85% of children with CHD survive into adulthood. But these adults have their own complications and challenges and have to be continuously monitored as well. But that's not necessarily the case elsewhere in the world. A lot of these are not necessarily caught elsewhere. Severe CHD can lead to heart failure, arrhythmias, and development delays and growth issues in children. So it's important, and risk of stroke, etc. So it's important to be able to detect them. And obviously can lead to high infant mortality rates. And as you can imagine, surgery on these patients is extremely challenging because of the scale. There's many of these patients face increased risk of heart failure, arrhythmias, and other cardiovascular issues. Genetic mutations is a big factor. For example, Down syndrome for these patients. Maternal factors such as infections, poorly controlled diabetes, or exposure to sarin medications or drugs or alcohol are also major risk factors. So it's important to be able to observe, for pregnant ladies, to observe these other potential risk factors and potentially estimate the risk of complications. I think we talked about the other options. When it comes, I think this is the last of the diseases that we'll talk about, but aortic aneurysms are diseases, and specifically aneurysms, where you have the enlargement of the aorta or a segment of the artery. And there, the risk, similar to the cerebrovascular aneurysms, there's a risk of rupture. But it's this abdominal, in the abdomen, your main aorta, this is the risk of death is significant. So once a rupture happens, the risk of death is up to 90%. So it's almost like definite. Thoracic aortic aneurysms are also quite common. Cerebral aneurysms, as we discussed, 50% of those ruptures lead to death, and we have peripheral aneurysms, but the risk there is primarily clot formation that may dislodge and lead to emboli and risk of stroke. Typically, this is detected sometimes, a lot of times accidentally, but typically detected with CT, MRI, or ultrasound angiography. It may manifest as pain or a bulging of the abdomen and so forth. So if you have a bulge, or you may actually have a pulsing abdomen, and you know, the patient may have other symptoms, as I said, like the abdominal pain or headaches and so forth. It affects about 1 to 2% of men over the age of 65 and is less common in women. In the US, around 200,000 people are diagnosed annually with abdominal aortic aneurysm or AAA, though many remain asymptomatic. That's the problem. The prevalence of AAA has decreased in recent years due to reduced smoking rates. So smoking is a big, big factor in aneurysms and peripheral artery disease and generally atherosclerosis. Ruptured AAA carries a high risk of death, as was mentioned. So many of these patients die before even getting to the hospital or surgery. So risk factors, smoking, has a 7-fold increase. So again, as you can imagine, this is significant, and you still see many people smoking, but you know, they're just not aware of the potential risks. 7-fold increase in AAA compared to non-smokers. Other factors obviously include age, high blood pressure, and atherosclerosis. So it's very important to be able to have some sort of screening to be able to estimate that this is present. Typically, this is done with ultrasound, but you know, the ultrasound itself is obviously non-invasive, but there's potential for detecting it with other methods as well through the abdomen. So in terms of now the risk factors, there's for all of these diseases, there's various risk factors: obesity, hypertension, diabetes, sleep apnea is a big risk factor, something we don't maybe pay much attention to, but it's been proven and shown that sleep apnea greatly contributes to various other diseases, and specifically cardiovascular disease. Genetics is becoming more and more important, and nowadays it's very cheap to get a sequencing done. For a few $100s, you can get a complete sequencing done and identify potential genes that are perhaps determining your risk or disposition to various diseases. Smoking, stress, alcohol, and drugs. As I mentioned, a lot of these risk factors, a lot of times, are a lot easier to measure than direct biomarkers of the disease, for example, or symptoms of that disease. So when it comes to obesity, 600 million adults were estimated to having obesity globally, with prevalence doubling between 1980 and 2015. It's estimated that up to 49% of the world's population, roughly 3.5 billion, are overweight or obese. In 2015, high BMI was associated with 4 million deaths. That's body to mass index ratio, over 2/3 of which were due to cardiovascular disease. So BMI, increased BMI, directly contributes to cardiovascular disease. So it's a very important risk factor. The burden of elevated BMI remains significant even after adjusting for smoking and other health issues. So BMI alone itself is an independent factor, okay, risk factor. So if you're the definition of overweight is a BMI between 25 and 29, indicates that the person has more body weight than is considered healthy. And there's obviously different classes between 30 to 35 and 35 to 39. Obviously, you don't want to be anywhere near any of these. But what's important is with a 1-point increment in the BMI value leads to approximately 5% increase in the risk of AFib, atrial fibrillation. So just the direct measurement of this gives you a proportionate estimate of your risk of AFib and potential complications. We already talked about AFib and the risks that it has on stroke and so forth. There's various other studies that look at the hazard ratio of obesity and whether as they lose weight, what potential improvements they have or not. And there's a 41% adjusted increase in AFib risk compared to those maintaining their BMI, for example. So it's all of them very important factors. So hypertension is another risk factor. I just want to speed up because I know over time. So hypertension is a very important risk factor. High blood pressure causes constant stress on the wall of the blood vessels and can lead to damage over time, can lead to dilation, aneurysms, atherosclerosis, and so forth. And the impact on the heart is significant as well. You may lead to hypertrophy, increased risk of heart failure, and increased risk of coronary artery disease. But hypertension is easy for us to measure, and you can quantify it. While we know statistically the correlation of hypertension to various other cardiovascular diseases, and maybe those are not so easy to measure, but hypertension itself is fairly straightforward. Sure, we could have better ways of measuring hypertension continuously, minimally invasively, but it's not sure if you can hear me still because I think my screen paused. Are you able to hear me?
Yes, we can hear you. We can hear you.
Okay. Yeah, my screen, my webcam for some reason paused. So when it comes to hypertension, there's about 1.1 billion people worldwide that have hypertension but are unaware. And this is despite hypertension being such an easy or a measurable measurand, it's an observable measure. But unfortunately, still 46% are just unaware. And it's a contributor to 50% of heart attack strokes in the US. Only half of it, half of patients with hypertension have it under control. So majority of these patients are unaware, and being able to detect it and estimate it is very important. Okay. When it comes to diabetes, the role of diabetes is significant in cardiovascular disease. When it comes to atherosclerosis, high blood sugar accelerates plaque buildup and atherosclerosis, and increases the risk of coronary artery disease by 2 to 4 times. It increases the risk of stroke by 5-fold, with more severe outcomes, and it increases the risk of peripheral artery disease 2 to 3-fold. So it's very important to have diabetes under management. But unfortunately, while such a large segment of our population, many of us probably in this audience, have diabetes, but many are unaware. Okay. So this it's also expected to grow, including so now, for example, in the US, 38 million people have diabetes, including both that are diagnosed and non-diagnosed. I'm not sure if I should have a figure of those that are unaware. Yes, yeah. So 44.7% of adults with diabetes are undiagnosed. So this is very important because it has such severe consequences if you don't have it under management. But it's very easy to diagnose it again. So unfortunately, it's a standing issue. This is particularly high in low and middle income countries, where 3 out of 4 people with diabetes live there, but they're just unaware. So it's important to have early intervention and to manage diabetes to prevent all of these various other problems that we talked about. The other risk factor is sleep apnea. Sleep apnea increases our blood pressure or leads to hypertension. It leads to arrhythmias. it leads to heart failure, it leads to coronary artery disease, and increases the risk of stroke and sudden cardiac death. And again, it's something that many of us have, and we just do not know or don't have it under control. And it also contributes to the epicardial fat thickness, which is independent of BMI, independent of body fat. There's studies that show your, cardiac fat, it changes just as a function of sleep apnea and lack of oxygen. So high rates in middle-aged adults, around 26% of adults. So probably again, 15 in this group have sleep apnea, and 85% of adults with sleep apnea are undiagnosed. So about 12 of us don't even know of this group of 15. So millions literally don't know that they have sleep apnea and has severe consequences. Again, something that's very easy to quantify and measure and observe. But we have to see where the problem lies in adoption, obviously, right? Or having an accessible solution that's cheap and effective. And as underdiagnosed in women, which is unfortunate, but it's the case, something that to study, especially post menopausal, it's becomes sleep apnea becomes a severe issue. Then the other factor, as we briefly touched on, is the genetic factors. This is again becoming far more accessible and available, and there's many genes that are known to predispose people to various increased risks. For example, these two genes, APOE and LDLR, accelerate or increase the risk of heart attacks and stroke by up to 50%. And but it's for the familiar FH, hypercholesterolemia. This increases the risk factor. This gene increases the risk factor 10 to 20-fold. So some genes, it's estimated, that if you have these gene factors, drastically increases your risks. So it's very important to be able to detect them early on. And 90% of those with FH remain undiagnosed. So again, by doing genetic sequencing and analyzing these, you could help a lot of patients. And for example, again, some gene factors can double risk of atrial fibrillation or hypertension, such as, for example, these two genes. We already talked about hypertrophic cardiomyopathy. That was, basically mostly familial and genetic inheritance, and it's been shown that the corresponding genes can lead to HCM. Same with congenital heart defects and arrhythmias. There's genes that are identified that correspondingly adjust the risk. There's many other risk factors like stress and lifestyle and alcohol and drugs and but this is the last one we'll touch on. But smoking, hopefully by now this is established, but I see still many people smoking, so I don't know. But it increases the risk for atherosclerosis up to 4 times. Coronary artery disease, the same. For stroke risk, increases risk by 50%. Peripheral artery disease, we already talked 5 to 7%, 7-fold, sorry, and so forth. So it's a big problem. But as I said, don't forget the other risk factors like alcohol and cocaine and stress and so forth. So now let's just take a 5-minute break and come back at 1:15, and then we'll talk about some solution generation strategies and need identification processes. Okay, so I'll just pause now.
Thank you. We'll come back at 1:15. Hope you heard that.
Okay, so welcome back. So now I guess you learned about all these diseases, and there are many, many more. So it's very hard for me to sort of give an umbrella image of what's out there. But I thought it's important to start from the clinical problems and their significance first. But what are potential solution strategies? And then I'll dive into how do we assess these various needs and how do we prioritize what we should work on. But specifically when it comes to these cardiovascular diseases, I think it's important to identify new efficient methods for measurement of various biomarkers and analysis of corresponding data to predict various cardiovascular conditions. We have a lot of data out there, but very little of it is actually meaningful, or not. I shouldn't say meaningful. We've made sense of very little of it, or we're not able to correlate that to meaningful patient planning or decision making or diagnosis. So understanding that information and summarizing them and directing them to action plans is a big gap. So how do we take all the information that you could have from all those various gadgets and sensors, and how can you actually relate that and reflect that to the clinician to a meaningful action plan? And ultimately to help make a path for therapy, an optimized therapy plan or delivery of it. Okay, so those are all outstanding needs that have to be addressed. As I mentioned, when we talked about all these various cardiovascular diseases, one recurring message was a lot of them are underdiagnosed. Right? So a lot of patients don't know they even have these conditions, and that's why we have a lot of these issues. So increasing that awareness of the potential risk is itself a very important endeavor. As I mentioned, and I maybe inappropriately joked, but a lot of us rather die than change our habits and lifestyle. So how do we address that? That itself is a big outstanding need, and it's a very good thing to, I think, address. Then based on all these cardiovascular diseases that we touched on, for each one of those specific diseases, based on the potential, obviously, significance, you can have tailored solutions that specifically only target monitoring it. For example, let's say if I have a gene factor for a specific condition, I could have a wearable device that's continuously only monitoring for symptoms or measurements of correlating to that specific disease. Like let's say I have hypertrophic cardiomyopathy and corresponding gene factors, I know I'm more prone or likely to develop it. But ideally, I would like to continuously have an estimate of what the condition is, and I could have maybe a tailored stethoscope that's digitally worn continuously and is continuously, for example, monitoring or listening to variations in the sounds of my heart. And for example, right, and that's just as an example, but you could have stuff that's tailored for specific diseases. The other area which is quite hot and is becoming more accessible with cheaper accessible electronics, is just the fusion of all these various information sources. So for example, like, you have your digital stethoscope that listens to heart sounds. You have electrodes, wearable electrodes. Now a lot of companies working on that front, and that continuously look at your biopotentials or cardiac electrical activity. You could have optical solutions that look at the volume changes of your torso or fingertips to look at blood changes, or look at oxygenation and its corresponding variations at various light frequencies. You may have various other optical solutions just merely looking at your body, and there you have sensors such as the conventional blood pressure monitor or the cuff that looks at the pressure and its corresponding variations. But few solutions merge all of these together and to provide more in-depth intel and correlate all them. And obviously, big data plays a role, is a significant part of this. and how do you use all that to correlate it ultimately to better prediction of the status of a specific disease, and hopefully leveraging the other factors such as the genetic information and the patient's habitual lifestyles and so forth, and their diet and so forth. So it's important, again, just to brief, I think leveraging these risk factors, fusing of these sensory information, and bridging the gap between the patient and the clinician for making sense of all of this data is all very important in this domain. So now how do we identify a specific need, and how do we brainstorm, and how do we select among these needs? And this brings to the second part of my talk, and I'll try to be efficient in timing so we have some Q&A time. So as we're trying to identify, sorry, let me close the window. Sorry about that. So as you're trying to identify the various needs, I think it's important to have a systematic approach for your selection and filtering. And this is what I do, and what I was trained to do as part of my medical innovation fellowship. It's based on the biodesign program that came out of Stanford, and that's a very valuable reference that I'm using in these slides, and I would encourage you to go over. So how do you conduct an interview? How do you observe a clinician or a patient? How do you form a need statement? What is a need statement? And making sure that you understand the clinical aspects of the problem. And how do you analyze existing solutions? How do you consider the various stakeholders for potential solution, and the market, which is obviously key, but how that very difficult to translate the technology on this. You have some government initiatives supporting it. And ultimately, how do those play a role into your selection criteria? So I think one of the important things is have a strategic focus. I really like this quote from Steve Jobs. And he says, deciding what not to do is as important as deciding what to do. And my mantras are focus and simplicity. And I fully agree. You have to focus. You can't be too distracted. Otherwise, you won't have deep insight. And you have to aim for the simplest solutions. And he was talking about the heavily complicated digital domain, but it's even more critical in the healthcare domain, because complicated solutions have a very difficult time clinically getting adopted or going through regulatory and reimbursement. So you need to aim for the simplest possible solution that you can quantify in terms of performance and added value. What are the important factors for your strategic focus, the areas that you focus on? Obviously, your own passion. Maybe there's a personal cause, there's a personal family history in a given disease. So that you may have a personal drive or mission. You may have a team that's extremely strong in one domain. For example, like, if you have one of you has a father who's a expert in peripheral artery disease, for example, or somebody like, you may have a network, personally have an experience or background on one of these diseases. So that itself plays a big role. Access to facilities, equipments, experts, and patients are all very important. Funding and timeline is very important, and potential strategic partnerships. So you may have all of those used to select your strategic focus, and then how do you decide? Your acceptance criteria should take into account for potentials on all these various factors, such as market dynamics and the competition. What does that market look like? Is it growing or is it declining? For example, the resources required to achieve the results is also very important. How much resources and energy do you need to do this? Is that even feasible? Effect on affordability and accessibility of care now becoming much more of a hot topic, and being pushed by reimbursement bodies as well. and the potential effect you could have on improving the healthcare outcomes, and like what is the really opportunity here in terms of adding value. So all of these lead into your selection of your strategic focus. Then once you have a focus area, then you start, this is at least how I do it, like, you start interviews with clinicians and experts. And this would also, also include reading the literature, obviously, and randomized trials in the field, and correspondingly review papers. But you have to go out there and speak with folks, so you have to get out of your comfort zone. You have to be observant and open-minded, so you don't go into these meetings with a biased perspective, with a potential solution. You have to be completely open to hearing their input, and your questions should be open-ended. So you let them lead you to where the problems are, not the other way around. So you don't want to imply answers or seek confirmation. And it's very difficult to do. We all have a tendency to do this. But ideally, when you're going to speak with these key opinion leaders or clinicians or patients, you have to be providing them with open-ended questions and letting them guide you towards the problems. But while you do that, you have to also be aware that you cannot just depend on these folks to identify the pain or need. And many times the biggest opportunities are in problems that are not yet identified as a problem. But it's for you to extract that information out of that interview. So for example, you may be observing an inefficiency, or they may be complaining about an inefficiency, but they don't know where the source of the problem is. And they can't bring that, they can't formulate that, and they can't give you that information explicitly, but it's for you to extract that. So to be able to have these conversations effectively, I think it's very important to educate yourself, know the disease state, know the treatment options, a lot of them we talked about today, know the various stakeholders, and make sure you read the latest randomized clinical studies if there exists on the corresponding disease and treatment options, and use your online literature to analyze it. So one of the things definitely you shouldn't do is you should not go into that meeting and hope to learn it in that conversation. You should definitely educate yourself in advance. I've personally had bad experiences that doesn't turn out well, and you lose a significant opportunity. And you want to save face, and you want to be able to go back to those conversations and make a positive impact. When you're looking at these procedures, or when you're speaking with clinicians or looking at the data, one key thing that I often look at is failures. Where do things go wrong? Where do we have, for example, false positives, or where do we have, a treatment failure or a complication rate? I try to observe tone and frustration with various aspects of the whole process to see what is really that annoys them, and identify time-consuming activities. And this, some of these are on the clinical front, like technical experience. To what extent does the staff or clinician need technical skills to do something? That's usually not a good sign. The technology should take care of itself. You should not need many years of experience gained. That's usually a weakness of the technology. You should be able to study it and apply it. So there's sometimes opportunities there if you heavily are dependent on technical skills of the staff. Again, be aware of biases, your own and others, on the innovation, on the patent, on the problem, and so forth. Make sure you take detailed notes, and best to work as a team, because they will have different observations, and they should all take notes in parallel. Obtain as much information as you can regarding your observation. What were the circumstances, occurrence rates, implications, costs involved, and so forth. And then you use all of that to formulate a need statement. So what is the problem? What is the population group? What is the outcome? For example, a need statement could be like a way to address this specific problem in population, why that has such an outcome. For example, to minimize the risk of infection in prosthetic implants, or to accelerate the recovery of disabled patients with partial nerve damage. So this is your need statement. And for that, you're trying to generate a solution. So it's very important to have that need statement, I think, to sort of formulate your thinking process. And then you start to screen the various needs. What is the potential impact of the problem on the patient? Can you quantify it? This is very important. And if you're not able to quantify the problem or the potential effects of your solution, and I can't overemphasize this, you'll have a very difficult time selling your argument. Okay, so whether this is an investor or a clinical body. So it's very important to be able to have objective data on either end from the existing problem and the added value of your solution. You should look at the impact on the healthcare system and look at the corresponding statistics and the prevalence and the incidence rates and so forth, and make sure you have objective insight. Okay, so we have to make sure this problem is a significant problem with many patients, or it's justifiable given the costs, and because you can always focus on different options. Is this the most optimized, or not the most optimized, but is this an efficient investment of your time and resources? You have to know what other solutions exist on the market. How are they used? Where are they used? Why not in this region? Why in this region? What are the limitations, pros and cons, and so forth? Who are the players? What is the IP landscape like? What is the pricing like? What is the regulatory landscape like? Is it a single use or a multi-use device? What are the features and so forth? And it's extremely important to understand the stakeholders. Obviously, for an unmet need, you have the patient, but you have their families, you have patient advocacy groups, you have the physician, professional societies, nurses, facility administrators, public payers. Don't underestimate their importance, the government bodies, regulatory bodies, and so forth. So all these stakeholders have to be taken into account. And if you fail miserably in one of them, you probably have a major obstruction for transfer. Obviously, the clinician is a major stakeholder. It's important to partner with a clinician and ideally a key opinion leader, not just, while it's important to consult with your average clinician, but it's very important to get the insights of the key opinion leaders who have a vision of where the field is heading, and they'll be able to comprehend your solution better than others. Because a lot of conventional clinical practice is based on practice, like it's based on doing what you're used to do and what you're trained to do. You don't want to explore something completely new. But those key opinion leaders would be brave enough to explore new opportunities. A lot of the traditional clinicians won't have that mindset. So it's important to consult with these key opinion leaders that are brave and fierce. So you have to, again, like a lot of these questions that I asked, you have to see whether they're open to collaboration. Will they gain a competitive advantage if they use your technology? So will they be an early adapter? Would it improve their patient outcomes? Would they like to recommend it to their patients? Do they have a conflict of interest? That's also something that you have to subtly figure out. Are they willing to pay for the solution? That's ultimately the key. I mean, like, are they willing to have their patients pay for it or to push regulatory bodies to pay for it? Then there's the staff. You have to ask, how does my solution affect the staff? Let's say you have something that drastically facilitates the life of the clinician, but puts major burden on the staff. Well, they're going to find a way or an excuse to avoid using it. So the nurses have to be okay with it. Does it increase their responsibilities or reduce it? Or and then you have to figure out the folks that are involved, are they unionized or not unionized, and would they champion your solution or not, right? And obviously, the patient, you have to ask whether they're the decision maker. Is this something they're going to pay out of pocket? Can they decide for themselves, or is it going to be reimbursed? Do they need it? Can they provide you with feedback, which is extremely valuable? What's their demographics and statistics, their alternative options, and so forth. And same with the hospitals. What is it in it for them? Are you reducing their costs, or are you adding to their costs? And which hospitals would be potential acquirers locally in Canada, US, elsewhere, in lower income countries? And how does it impact the hospital's marketing for recruiting more patients? For example, like the Da Vinci robot, it adds cost, but it helps recruit more patients. So it's a marketing campaign, and so forth. You also have to take into account the existing competition. Sometimes hospitals have existing deals with other distributors or other partners to limit their options for recruiting new partners. In terms of insurance, this is a very key thing that you have to identify. Who's going to pay for it? Is it reimbursable? Is there an existing CPT or existing code for reimbursement? How will a solution impact the revenue of the insurance company? So are they willing to support it and reimburse it? Will it replace existing alternatives at a lower cost or no? Will it reduce their number of claims? So if you can prove that downstream you will have lower costs, for example, due to rehabilitation for stroke, therefore you need to do this early prevention and it justifies your cost burden now, but those numbers you have to prove, then that's something perhaps they're willing to consider, right? And how does it adjust the quality of adjusted life years? That's a key metric that they use for assessing reimbursement of various technology. I think an average value of a quality is like in the domain, it's about $50,000-$60,000, for example, per each year added they're willing to reimburse. And obviously the government is important as well, and correspondingly regulatory bodies. In terms of the market size, this is often quite tricky if you just go to these reports. I like this cartoon. I mean, but it's true that sometimes it's very difficult to get your hands on accurate market data. But I personally prefer a bottom-up approach. So starting from actually the number of cases, using the number of procedures or the number of cases or the patient groups is usually the best estimate, and relying on a lot of these market reports that give you a dollar sign for the total market. Using the patient distribution and demographics, I find this personally better. There's many references for this. And so, yeah, cost per patient and procedure, and you can look at Medicare or Medicaid data to see reimbursements that's publicly available, and many other resources to help you estimate the value or the potential market. And then ultimately, just quickly wrapping up, when you want to use all of this, how do you select the top project that you want to work on? Let's say you've identified 4 or 5 or 10, hopefully a lot more, and you have potential ideas for each of them. But then what is the market size? And so we actually, this is based on the biodesign, but we did the same. I generated this MATLAB code at the time that would help us rank all of our, you can do it with an Excel sheet, based on the weight of each one of these criteria that you have. Can you rank different projects? And I still do this. So, what is the market size? What is the patient impact? What is the provider impact? What is the need, unmet need, distribution, demographics, and what is the feasibility? This is extremely important. Is it going to be a 20-year research project, or is it going to be potentially leading to a solution in the next couple of years? Or is it going to be happening something much shorter, or depending on, what you want to do. But if you want to do clinical transfer, then you got to aim for unless you want to do long-term research, which is extremely valuable. But if you want to have more immediate clinical adoption in the next 5-10 years, then feasibility becomes extremely important. So based on all of those factors, you weight and categorize the various projects, and you may have a long list, and you then use this multi-criteria weighing to prioritize your needs and corresponding solutions. It's very important to understand the root causes of the problem. So just sufficing, this is the problem, without understanding what the root causes are that lead to that problem is inadequate. And once you understand the problem at its core, a solution just naturally, I think, emerges most of the time. So once you understand that root cause, you should invest a lot to understand it. And a lot of times people haven't been able to generate a solution because they haven't understood the problem well. So then you can set yourself apart by understanding the root causes. Then you go out there and innovate and you have fun. And in that thinking process, you want to be brave and you want to be completely innovative. And as Einstein says, I never made one of my discoveries through the process of rational thinking. So it's okay to be rational. It's okay to have silly ideas, and it's okay to that help maybe come up with other ideas that do make sense. And the only way to have good ideas is to have lots of them, and I think this is true. So with that, I thank you, and I wish you the very best in this program. And I'm sure you'll do great things, and I'm happy to help.
Thank you so much for the inspiring, detailed talk, Professor Tavali. Hope you all are charged enough to dive into the problem and work as a team to find an innovative solution. You can unmute yourself and please ask questions or put it in the chat, please. Please go ahead and ask, Nargis.
Hi, thank you very much for your presentation, Dr. Tavali. I really enjoyed it. I would like to know that if for this application we require to mention how many, let's say, healthcare providers we have talked with, like, do we need to really mention how many people we have been engaged with, or we can just highlight the outcome of our conversations?
I think it's always important to mention who you've spoken with, but ideally also categorize them, which groups they're coming from. So whether these clinicians, like 5 clinicians, 2 nurses, like 10 patients, for example, that gives that insight that you've done your due diligence. And if you haven't done that, then doesn't look too good. Ideally, like for example, like I remember I once had this advice from one of my advisors that he told me, like, go to the next clinically relevant conference, if possible. Now we have the MedTech event coming in Toronto, so which is a good opportunity, for example, and I think it's free for students. But anyway, so you go to these events or you go to the corresponding literature or whatnot. But it's important to be able to say, okay, I've spoken with 30 cardiologists, and they've all identified problems X and Y, and they've all said, I have challenges in this, or this portion of them said they have this, the other portion didn't say, but gives you an idea of the distribution. They don't all have to confirm it, but as long as a reasonable portion of them do reconfirm that need or the existence of it, that I think is extremely valuable. Hopefully that answers your question.
Yeah, thank you very much. Thanks. Yeah.
My pleasure.
You can put your questions in the chat or unmute yourself and ask. Yes, Mohan.
Hi there. Thank you so much for the presentation. I just arrived to Canada, so my internet is a bit dodgy. So I may ask a question that might seem a bit redundant, but I'll just ask it anyway. Are you expecting like a working model from us? Or are you expecting us to present a model that could potentially lead to something in a very tangible result?
At least personally, no, given the timeline. I don't think it's reasonable to expect like a working prototype, but everything like the design or the concept or the need and the market and everything, like the landscape, all of those other factors should be there. But to have a necessarily working prototype, I don't think it's necessarily feasible in a lot of the cases. I mean, obviously, if you can have it, great, it adds a lot of value, but I don't think in many cases it's actually feasible. But I'm not sure what the program managers have in mind. I mean, this is my personal perspective.
Yeah, we have to consider the time constraints. So
Yeah.
whatever the best they could do, we should accept.
Yeah, I agree. I think given the short time period to just expect a feasible, like depends on what the tool is. I mean, if the tool is just a simple questionnaire, then it's probably feasible. But if the tool is like some gadget that's has hardware components, probably like a big chunk of that is not going to be feasible in the given time.
All right. Thank you so much.
My pleasure.
Zachary, please go ahead.
Hi, Mayor. Thank you, Ali, for your presentation. Yeah, it was really interesting indeed. I also have a question. Actually, I wasn't there at the first part because I had another meeting, so I'm not sure if you've already answered that, but I'm still gonna ask it anyway. After the, you know, the whole the whole project per se, like we go through week one, two, three, and then at the end we pitch the I mean our solutions that we provided. Is there something afterwards, or that's basically the end? Like there's no some sort of I don't know, because I from what I understand, MedTech is a tech talent accelerator, so I would assume that there will be something afterwards in the sense of like maybe perhaps going to other pitch conferences or something like that. But just guide me here so I can understand better.
I guess I can pass that on to Marie. My understanding is obviously the best projects win the awards, and that should, I mean, if you're definitely interested in pursuing it, that should provide some initial seed money to help you pursue it further. But I'm not sure if there's support provided by the program for continuation of those selected projects from as an incubator or whatnot. I'm not sure. Can you comment maybe, Mary, or?
Yeah, at this time, I cannot promise anything, but we will try to guide you. That's all we can promise.
Yeah, but what I would say is if one team ends up winning or the top three, for example, probably a lot of folks are going to be motivated to help you, because they know obviously you've passed a lot of filters to get there. So it's not, it has merit to it. So, and a lot of folks will be, I think, happy to help, at least myself included for sure, just to provide some mentorship and consulting.
Great. Thank you. I appreciate it.
Thank you. Thank you, Mohammed, please.
Well, thank you very much, Dr. Tavale. Thank you, Mary Susan. It's good to see you again. This was very informative. While going through cardiovascular disease, I mean, it is a heterogeneous disease with several, multi-system consequences. But I don't believe I saw mention of congestive heart failure or just heart failure in general in your presentation. And I wonder if the scope includes a heart failure as a cardiovascular disease.
Yeah, so yeah, definitely. There's many other diseases, specific ones that I didn't touch on, why I did touch on like cardiomyopathy, for example, and whatnot, or valvular diseases specifically. But a lot of the other diseases just don't have the bandwidth to touch on, But a lot of, for example, a good chunk of them fall under these categories of atherosclerosis, aortic disease, arrhythmias, and valvular disease. But there's a lot of other ones. So anything that's in the cardiovascular space, definitely do it. But you have to justify it that, there's a significant problem. Why? You have to have an objective method of quantifying it. And there's a potential route for generating a solution that has all the means for being adopted. Right? And how, if you do, how do you measure those potential impacts? And is it measurable? So you can convince the the buyers and the reimbursement folks to actually pay for it. But yeah, definitely your hands are not tied to specific diseases I touch. I just try to, because I think I touched on too many because of time, as you saw, it's that's not feasible.
Well, thank you very much. Mary Susan, I wonder if the scope, because 3 weeks is a short time for a viable prototype. What kind of deliverable are you looking for?
Professor Ali.
Yeah. So I think given this timeline, what I think is identifying the need is a big chunk of it. And that's selection criteria. And then having an assessment, having some idea formulated that's sound and proper with the potential methods of adaptation and potential methods for objective quantification of its performance are all key. But of course, some insight on what that idea is key to it. You can't just say, well, we need a solution. No, but what is the solution going to be in terms of brainstorming for various ideas and seeing their feasibility and assessing. But to generate a working prototype is obviously, I think, beyond the scope as we touched on. I think, but the other factors, a lot of them could be formulated in terms of like the landscape, in terms of market, payers, stakeholders, potential solutions. What is the IP landscape, feasibility, the method for quantifying it or assessing it, and so forth. All these other factors could be.
I see. Great. Well, that was very informative. Thank you very much.
My pleasure.
And thank you, Ms. Thompson.
Are there any other questions? I don't see any hand. There are no questions in the chat. Are we good?
Everybody's ready to get to it.
Yeah. Okay.
So can I just ask one more question, if you don't mind?
Yes, please.
Yes. Thank you again for hosting the amazing session today. And I'm sure that like a lot of us would have questions in the future. So, to who should we go to if you have any questions?
Okay, so in the welcome package, I have given you the names of the mentors and a mentor check-in form. So if you have any questions, please put those in the mentor check-in form and I'll connect you with the mentors.
All right. Thank you so much. Just another follow-up question. Do we have to attend any other session later today, or is it all today? Is this the only session today?
This is the only session today. This is the launch event, and you got the problem, and now you have to start finding the solution.
All right. Thank you so much, ma'am.
Thank you.
Thank you, everyone. Best of luck.
Okay. Thank you, everyone. Thank you, Professor Tavali, again. And hope we will meet again on October 23rd. And before that, please submit your group registration form. Please submit the check-in every week. And please ask me if you have questions or anything, anytime, please reach out to me. I'll connect you with the right person. Okay?
Thank you.
Thank you very much. Okay, have a good day. Bye.
Thank you. Bye.
Bye. Thank you.
Bye.
Bye.